respected teachers, my senior and junior colleagues, Assalamu alaikum. Sorry for the very big interruption. I am asking you all for attending my presentation. So the title of our study was Perioperative and Oncological Outcome Following Open Radical Cystectomy for Bladder Cancer. It was a single center experience in Dhaka, and the center was Suhrawardy Medical College Hospital, our very beloved institute, very wonderful institute. So our main author was Associate Professor Moazzam Hossain sir. He is also present here, and I am Dr. Shamsul Arefin, working as registrar from Department of Urology. So the background: gold standard therapy. Radical cystectomy combined with pelvic lymph node dissection and urinary diversion remains the benchmark for gold standard of clinical care in both case of muscle invasive bladder cancer and highly recurrent high risk non-muscle invasive bladder cancer. So the regional healthcare challenge: urological practice across the Bangladesh deals with unique challenges. Patient cohorts present primarily with high smoker incidence, delayed medical check times, and nutritional deficiencies, making the major open pelvic surgery resection very high demanding. Understanding the baseline outcome at a prominent institute in Dhaka provides a reference model for local surgical protocol. So our institutional study objective was to analyze the internal baseline operative criteria such as the median surgical time, surgical margin status, immediate post-operative complications, blood management policies, average length of post-operative hospital stay. And in case of oncological and survival outcome, our goal was to determine the early and intermediate oncological efficiency, local recurrence trend, distal metastasis pattern, calculate the overall survival alongside the disease-free survival. So it was a retrospective clinical audit we conducted in our institute. So the number of the total patient was 20. All included patients underwent definitive open radical cystectomy accompanied by complete pelvic dissection and with urinary reconstruction. So what we found in case of patients baseline studies, the age distribution ranges between the 40 to 66. Almost all the cases was the male patient, and in case of surgical indication, 80% was T2, and in case of surgical indication, 20% was T1 stage. And in case of T1 stage, 2 patients presented with rapid refractory early recurrence following high standard transurethral resection, which necessitating for cystectomy conversion. And in case of another 2 patients, tumor load was very massive with multifocal bladder tumor exceeding an individual size metric more than 6 centimeter. So as for the surgical resection, we try to adhere to the standard surgical protocol. So as you can see, what we have found that our total reconstructive time so in case of surgical metrics, so the mean operative time was 5 hours and 10 minutes. And in case of the length of the hospital stay, average length of the post-surgical stay was 2 weeks in most of the cases. And in case of bowel and resuscitation, our major focus was immediate post-operative management around the pelvic fluid collection, correction of electrolyte balance, post-ideal resection, active physiological support before the hospital discharge. So the length of the hospital stay, because of nutritional optimization, rehabilitation stays, and monitoring the patient bowel recovery. So in case of the surgical resection, we tried to adhere to the standard surgical protocol I have mentioned before. These were some of the steps: bowel anastomosis, post-cystectomy bowel excavation, and ileal conduit creation, and application of the ileal appliance. And as for the pathological specimen analysis, we analysis for the depth of the invasion, lymphovascular space invasion, the surgical resection margin status, and in case of pelvic lymph node tumor involvement. So what we have found in case of pathological staging profiling, around 55% cases was in P2 stage, 35% cases was in PT3 stage, and 10% number 2 patient was in PT1 stage. So in post-operative cases, minor complication happened in almost all the cases. Common complications included the superficial surgical site infection, the localized UTI, mild metabolic acid-base balance imbalance. And in case of bowel function, 10% cases in case of 2 patients happened with prolonged paralytic ileus, and major surgical complication happened in case of 3 patients, which was the wound dehiscence happened in 1 case, parastomal hernia in 1 case, and incisional hernia in 1 case. And as for the oncological and survival outcomes, disease-free survival was 75% cases, Recurrence or metastasis happened in case of 15%, number 3 cases, and cancer-related mortality happened in 10 cases. So in out of 3 recurrences, one was pelvic recurrence, 2 presented with distal lung and bone metastasis. So in the end, what I want to say that we have avenue for improvement. There is high perioperative morbidity documented directly mirrors the high rate of advanced disease at clinical presentation. So what we are thinking? We are thinking to adhere to the enhanced recovery protocol after surgery, which is called the ERAS protocol. If we can follow this ERAS protocol, then we can successfully reduce the current average surgical post-surgical stay below 2 weeks baseline. So if we ask me what is the most difficult part of doing the radical cystectomy, I will always say it is the counseling part, because to convince a patient to stay his life over a stoma is very difficult. Thank you all.